Yeah, sir, you are live now. Yeah.
Very good evening to one and all. We welcome you all to the 5th chapter of Season 2 of Youthful IRSI. This month, we will be discussing a topic that has taken our society with all its grip, the myopia boom. Thank you, one and all, for being a part of this important topic to be discussed on Youthful IRSI. In today's chapter, we are going to be talking on myopia boom. What is myopia? What is the treatment of myopia? How to manage myopia of the eye non-surgically? And what all are the options that we have for surgical intervention? We have with us an experienced team today talking to us about surgical as well as non-surgical management of myopia. I would request Dr. Himanshu Mehta, past president of IRSI, to please open this topic today.
Evening, Ron. Thank you so much. And thank you for having such a wonderful team there and organizing and all of them sparing their valuable time. Thank you, Vaishali, Kareeshma, Adi, Pooja. I think it's a wonderful initiative. It's an explosion of myopia that we are going to be seeing. It's like the Chinese culture, despite us not having the Chinese eyes. And COVID has really precipitated the problem big time. There may be controversies on what kind of atropine to use, 0.01%, whether to use or not, whether or not it is the medicine ultimately, whether to use those progressive glasses. But one thing is certain, whatever we do, encouraging children to play in the open playground, like the good old Rabindra Sangeet, and playing in the open area rather than playing games on their iPad. All mothers have found an easy way out for feeding their children. I can see the smile on the mothers' faces, like that, giving them the iPad and or switching on the television. So if this could be avoided and that could be reduced as much as possible, a lot of myopic spasm reducing and playing in the open area. Studies have definitely shown that that would be definitely beneficial. Whether atropine works or not, whether the glasses work or not, is a thing which we're going to see in the next 10 years. So great initiative. One thing is certain for all the Lasik surgeons, you're going to have great work, because we worked hard 20 years ago to say that Lasik is a good surgery. People used to not believe us. 1994, US FDA approval came. In 1991, 92, when I was in the US studying, believe you me, when I saw the microkeratome working for the first time, I was thoroughly impressed. That what an art, what is an amazing way. That time there was no topography also. And then PRK came. Amazing. What definitive science that we have managed to get. And I still remember the first time Excimer was introduced was on the Los Angeles Academy, 1991. And that was my first meeting in the US, American Academy. It was mind-blowing to see what. And from where we have reached to where. You don't have to prove anymore to patients that Lasik is safe. You have evidence of a couple of million people in this world. So you have a great time to start. It's a great world to be. And thanks, Ron, Pooja, for organizing this. A lot of good programs have been there for the young ophthalmologists, the Youthful IRSI, including during the IRSI session, wherein you have those sessions where you have some of the best speakers who come and discuss during lunchtime all the personal problems, not just from the podium. I guess brilliant, all the very best, and all the very best. Looking forward to listening to all the accomplished speakers in the next few moments. Thanks. Over to you, Ron.
Thank you so much, sir. Thank you. Without further ado, we'd like to start our session. Dr. Pooja.
We welcome our very first speaker, Dr. Vaishali Vasavada, a phaco-refractive consultant at Raghudeep Eye Hospital. She's an expert in cataracts and glaucoma with a special interest pertaining to adult and pediatric cataracts. She has, of course, presented and won in multiple national and international conferences. We are so lucky to have her here today with us to talk to us on ICL in young myopes, the do's and do nots. Over to you, ma'am.
Thank you so much. Thank you, Pooja. Thank you, Rohan. Thank you, Himanshu sir. And thank you, IRSI, for having me as part of this webinar. And I really love the topic. I must say that talking about myopia, I think is the thing to do today. because we already are seeing a lot of myopes, and more we are going to see. So we need to be prepared to sort of manage them in the appropriate manner when they do come to us. Today, I will talk about the basic do's and don'ts for phakic IOLs. And I'll restrict my talk to posterior chamber phakic IOLs because that's what I have experience with. I have no financial interest in this presentation. So I think let's start with saying that who is a good patient for a phakic IOL? I think the first requirement for all of us is actually that the refraction should be stable for at least a year. Because a lot of the times when we choose patients for any of these phakic IOL procedures, they may be higher myopes or at least moderate myopes. And therefore, you want that the refraction is stable for at least a year. And for me, the cutoff, which was previously 18 complete or even 19 complete, I have now pushed it off to at least 20 years complete, because we do see sometimes that the patient comes back, if you did at 19 years and then they come back in 2 years, and what is so called regression or ineffectivity of the surgery is often a change in their axial length when we study them. So I think this is something which a lot of people globally are also changing. So that's a good patient. In terms of refractive error, all high myopes, I don't personally prefer to do a cornea-based refractive procedure, laser procedure. For anybody who is -9 diopters or more, yeah, I know that the femtosecond, I have access to the femtosecond Lasik. And a lot of the other platforms also, they support up to the FDA has approved up to -12. But I feel that when you're ablating a lot of tissue, plus the abrasions and the night vision problems might be more when you do that. So for me, it's 9 and above, it's usually ICL. And any degree of myopia with or without astigmatism or a plain astigmatism, where the cornea is even slightly suspicious for a corneal refractive surgery. So that's that. Now, what are the strict criteria that we should follow? The anterior chamber depth, it's said more than 3 millimeters, but yeah, in practice, sometimes even up to 2.8 we go. So, but it has to be at least above 2.8 to be able to qualify for a phakic IOL. Now, when we say 2.8, typically I would look at aqueous depth. That means the distance between the corneal endothelium and the crystalline lens, not the epithelium and the lens. I would want between the posterior surface of cornea and the lens. For me, a horizontal white to white corneal diameter of 11.5 or more also is a criteria. I have now, after learning the hard way, started doing gonioscopy for all these eyes, and angles have to be documented to be open without any synechia or without any signs of a Fuchs iridocyclitis, for example. And a specular microscopy where the endothelium cell count is more than 2000. What are these lenses made up of? We all know that they are made of a collamer material, and therefore we need to understand that the way we handle them will be very different from IOLs, which we all are very used to, which will come to in the later part of the talk. So what are the do's prior to planning a phakic IOL? You know that, okay, I'm planning a phakic IOL. What are the do's? Number one is a thorough preoperative evaluation of both eyes. And for me, the first thing is to look at the ocular surface. Now, when we say dry eye or ocular surface, you don't have to have a lippy view or a fancy diagnostic. All we need to do is have a careful slit lamp examination. And whenever you have a topography or any autorefractometer, biometry, where you are capturing images, look at the stability of the tear film on that image and teach your optometrist what an unstable tear film looks like. So I wanted just to show this example. On this side, where I'm pointing out left side, is the corneal aberrations in a patient who underwent a preoperative evaluation. And you can see a lot of trefoil coma, higher order aberrations. Now, you would typically count this out for any kind of a premium procedure. But when we treated the patient with lubricants, and this is 4 days after lubrication was started, the corneal aberrations are almost gone. The only what is left behind is astigmatism. And now suddenly this becomes an extremely treatable and gratifying case. So what I wanted to say is dry eyes, yes, they will cause surface symptoms post-operatively, but also they will lead to higher order aberrations. they will most importantly for a refractive surgeon give you a wrong estimation or a fluctuating estimation of the refractive error whenever you check that. So I think that is something which has to be evaluated before any refractive surgery. And like I said, I just look at the topography Myers. Now, if they appear to be regular and round, I'm okay, I'm happy. So please look at actual images rather than just some values that come written on your case sheet. That's what I would want to say. As a practice, we should document biometry for both eyes for two reasons. One, God forbid something were to go wrong during your ICL surgery and there is a lens injury. You have to have a biometry, but most importantly, even after that, it is good to have a documentation of the patient's axial length, their lens thickness in particular, and the biometry parameters. Checking corneal astigmatism and its regularity. An irregular cornea is not a good cornea for any kind of refractive procedure, be it corneal or even for an ICL. And what is very, very important, because you are doing something in the sulcus space, you are adding a foreign element, is to look at the corneal specular microscopy. If you don't have access to a specular, no problem. Go to your slit lamp, put your beams, the viewing beam and the illuminating beam at 45 degrees from each other and look at a specular reflection. I think that's a very good clinical indicator. And what I've learned following a publication from our team is that OCT is a must, and particularly in these high myopes. They may sometimes have subtle macular pathologies or extreme retinal thinning, which you may not be able to see even in the hands of a best retinal surgeon. Why is this important? Mostly to prognosticate, to tell them and to actually show them on an image that, yeah, your macula doesn't look the healthiest. So we will do an ICL, we will eliminate your refractive error, but your vision cannot improve because you have this certain problem. And similarly, for a high myope, which is typically an ICL patient, is evaluation of the peripheral retina, which is, I think, mandatory. And they have to be educated that even after the ICL, once the refractive error is knocked out, they better keep an eye on their retina once a year. And like I said, I always perform a gonioscopy, and this is something, I've taken this example to see there's a lot of pigment dispersion and you can see a little waviness in the iris. So these are the eyes I want to watch out for, particularly in the post-operative follow-up. Now, if somebody has an occludable angle, I would typically perform a peripheral iridotomy, a YAG PI, before I do the ICL, even if it's a centraflow. But usually luckily the myopes would not have occludable angles. Still, it's always a good idea to document, because spherophakic eyes, or those with really subclinical spherophakia, as I would like to say, sometimes the lens diaphragm is anteriorly pushed, and which is the reason also for the myopia. So please look at that before you do anything. One thing I wanted to show was how do you measure the white-to-white diameter? Because the entire game in a phakic IOL is the sizing of the lens. Now, as of today, there are many ways of measuring. There are these OCT-based or optical devices. There is a manual measurement, and there are UBM measurements, sulcus to sulcus. However, what the company recommends, the STAR, for example, and which is still the gold standard, is a manual measurement of the white-to-white diameter, and we like to use the digital vernier caliper. Now, this image, I always like to do it in the OT. I lie the patient down under the microscope, but this is a vernier caliper, and I took this specifically just to show that sometimes these bulky blades, patients get scared, and it's not easy to do under a drop of Paracane. So if you can get a good white-to-white, well and good. If the patient is squeezing or not allowing, the other good way to do, which is more practical, is take your standard caliper and put it on the white-to-white diameter. Now, don't use measurement from those markings because they're gross. Put this caliper on a paper. And these are the two dents that you can see here from that caliper. Now take your vernier caliper and measure exactly what is the white-to-white. So yeah, white-to-white measurement, I think, take your time and make sure that we do a good job at it, because that is the whole game of sizing. Then once you have evaluated, you know that the eye is suitable for an ICL, then comes the tough part of counseling. And although sometimes you don't want to tell too much to the patient, particularly negative news, because you're worried that the patient might go away. But I think it is important to discuss with them without scaring them, but just telling them that there are very rare problems. How I like to tell is that these are things that can happen. Typically, they don't happen, and I have very rarely seen them in my practice. So don't worry about it, but this is something you should know, that we might need a rotation, or we might need to exchange if there is a problem in the sizing, because we cannot go inside the eye and actually check the size of your internal space. And the fact that there sometimes rarely might be an early onset of a cataract. However, I must say that after the ICL with the central hole has come, which is the centra flow, I've practically stopped talking about cataract because we hardly see any lens changes. There are other manufacturers, and therefore, I mean, we have good Indian brands which make very good phakic IOLs, and I'm not against them, but I have more experience with the Star, and so I feel very confident doing an ICL in most eyes now. Now let's move on, in the interest of time, to what are the basic surgical tips for a phakic IOL. What I do want to emphasize is that when you're beginning a phakic IOL or in your early stages, please be very gentle in handling the eye, because they're very delicate and they're liable to tearing. These materials are not like your thick acrylic materials for the IOL. So you need to understand that the handling is more gentle, it's more delicate. And sizing still is, like I said, is a bit of an issue. Sometimes even with the best technology and the best lenses, we do end up in a little mismatch, or a high vault or a low vault. But mostly we are okay. Like I said, peripheral iridotomy is practically out now, because most phakic lenses now have a central port which allows the flow of aqueous, and therefore there is no role of a PI in today's date and time, really. The hole on the haptic, particularly, like I said, I have more experience with Star, no financial interest, should be on the right side. So that's the practical guide, and every lens has their own mark which you need to align. Now, I just wanted to show you, in my opinion, the most crucial part of the surgery is loading the lens in the cartridge. After that, it's not that difficult. So use this soft tipped plunger to gently position, and then use the grasping forceps to, as you can see, we are gently gliding this, but don't leave the grip. My only message is, when you are in this area, don't leave it, because if the ICL gets stuck in between, you've had it. It's going to be a really tough time. So make sure you gently pull it out through and through in its entire length. And typically what I will do is, I will not paint or drape the patient until this lens is loaded. Once I'm sure that my lens is successfully loaded, then I'll ask my assistant to drape the patient. Because of the fact that at least with Star, I can say that they don't give you a backup lens. Now, if something were to go wrong with this lens, and your patient is already draped and all the speculum has been put, all incision has been made, then you are going to be in trouble. So this is a practical tip I have found useful. Only start the surgery or put the speculum once you have loaded the lens. Now, in injection, what I and all surgeons at our hospitals like to do, we like to make a little larger incision. We use a 3.2 knife. And I want to go inside, and very gently I'm trying to inject the ICL. It is crucial to avoid any touch to the crystalline lens and the uveal tissue. So gently just push it in. The good part is it's really a very easy material to inject and implant. So it's not so much of a difficult proposition. Recently, I was in a meeting where there was a debate on what viscoelastic would you use in these eyes. Now, traditionally, we have been taught to use methyl cellulose, but we have given up on the use of methyl cellulose inside the eye for any procedure, including an ICL. And I now prefer to use sodium hyaluronate. It's easier to remove, and I'm not worried about a TAS or a postoperative inflammation. So therefore, I have switched to methyl. And after that, I think I've switched to sodium hyaluronate. And then you just tuck the haptics, first the leading ones, and then the sub-incisional ones please don't use any other instrument than the handler or the manipulator, because these are meant for these lenses. So I don't think that's a big deal. If your pupil goes small, I wouldn't hesitate in using intracameral adrenaline also to achieve maximal pupillary dilatation. And then keep your IA probe, bimanual or coaxial, whatever you're using, close to this central hole. This is the centra flow that we were talking about. And you will see that all the viscoelastic being cohesive, sodium hyaluronate being cohesive, comes out as a bolus. So it's much easier to remove also than methyl cellulose. You can see these whorls. If you can notice here, these are what you are trying to remove. And they will come out. Just be patient about that. This is a post-operative, this is an ideal vault. And I want to draw your attention to this suture here. Again, it's a debate or a controversy, but I do like to take a single suture because it's a 3.2 millimeter incision. And now that I do smaller and smaller incisions, even for cataract surgery, I would like to take a safety suture, which I'll remove after a week. And this is a well-placed ICL, a very good vault. That means the distance between the crystalline lens and the phakic lens, and a quiet eye, clear cornea. And we always document at every follow-up on OCT. Now here you can see this is an example where you don't have a great vault, but it's not bad. So for me, any vault, that means the distance between the phakic IOL and the crystalline lens, anywhere between about 450 to 650, 700 is an ideal vault. I also like to take a look at the angles on OCT. I don't do a gonioscopy early on because I don't want to put in any lens. So yeah, I think these are the do's, but only one don't I want to say is please don't forget to monitor these patients lifelong, particularly for the peripheral retina. Thank you so much. And thank you, Pooja. Thank you, Rohan.
Thank you, ma'am. Thank you so much. This was very detailed and excellent. One particular question I have, the raging controversy, people who have been put ICLs 10 years ago are coming back with cataracts. How much of that are you seeing in your practice, and how much of that has changed with the central hole that is present in the ICLs these days?
So that's a great question, Rohan. We are starting to see patients who have phakic lenses who come up for cataracts, but I see a lot of the older versions which did not have the central hole, and a few older designs from other manufacturers, not the Star, who have also now upgraded their designs. So I don't see any now with the centra flow. I don't see any recently operated ICLs, but yeah, you will see patients anyway. They are high myopes, so they are predestined to have early cataracts. But the great part is, one, biometry, not an issue. Just click and perform biometry and IOL calculation like you would do with a phakic eye. So you don't need to make any adjustments for the phakic IOL. And the other thing is removing this ICL or any phakic IOL from the eye during a surgery is not it's not a big deal. These are very pliable materials. So I think it's not a big concern for us in that sense. But like you rightly pointed out, we don't see, even if the lens, I have seen patients where the phakic lens and the crystalline lens are nearly touching, and yet these patients maintain clear lenses. So I think that's a great thing that has happened.
Ma'am, and one question. So if a patient comes to you post phakic IOL and has a cataract, and they chose to do the femtosecond cataract surgery, so how do you remove the lens first and then take the patient to the machine and then continue with phacoemulsification, or do you first do the laser part and then how do you go about with it?
Again, a very good question. And I think this is going to be more and more relevant. Now, good part with phakic lenses, it is the laser cannot penetrate any opaque medium. Now, because this is completely clear, the laser can penetrate. The only issue that will happen is you may have to manually adjust when you perform the anterior capsular axis, you may have to adjust that, yeah, this is the anterior capsule on your OCT. I have only done, I must say that I have only done one case who had a femtosecond cataract after the ICL, and where I did not remove the ICL, I did the femto first. And then, but I must say that I had two bridges in the rexis. These bridges are not like completely, there were no tears. I just was careful in sort of picking up the capsule with my rexis forceps. But I would appreciate comments from other panelists who may have had more experience with this. I think you can go ahead and do a flax and then just open the eye and remove the ICL.
Okay. So then it does not become a 3-step procedure. It stays the 2-step procedure that it is.
Yeah, I mean, I think that's true.
Okay. Okay. Thank you.
Thank you so much.
So now we'll move ahead to the next talk. Thank you so much, ma'am. And we'll have the discussion again after the second talk is over. Next, we have Dr. Aditya Sethi, a very dear friend who is an alumnus of Shankara Nethralaya, Chennai. He did his post-graduation along with his fellowship in pediatric ophthalmology and strabismus. He is a consultant at Arunday Eye Hospital in Gurgaon. Dr. Sethi is also an active elected member of the Young Ophthalmic Society of India, YOSI. And he will be talking to us today on a topic which is the need of the hour, the new Covid Myope, addressing the certain in uncertain times. Over to you, sir.
Thank you, Rohan. Thank you, Pooja. Thank you, sir. And thank you, IRSI, for this opportunity. I hope you guys can hear me clearly.
Clearly.
Get my presentation going. Yes. All right. So I think I'm going to talk about what comes before you do an ICL. That's how does myopia happen and what happened during COVID. So we all know about myopia. It's basically elongation of the eyeball. The axial length increases in these kids. And me being a pediatric ophthalmologist, also a refractive surgeon, I think it's the right forum for me to talk about this. Dr. Mehta also spoke about going outdoors, and that's been well documented that going outdoors is really, and sunlight really helps in preventing progression of myopia. So yes, that's been advocated, and we all want to speak the same language when we talk to our patients about going outdoors and lifestyle changes. Of course, that's another talk, another day, but that's exactly what happened in COVID. We were forced to keep our kids indoors, and those who already had parental myopia or had the habit of the screen got a reason to expand that, and let's see what happens. So I'm going to make it a little more interactive and probably get some case going. So the first thing is in 2019, these two siblings came to my OPD, and then let's talk about them. So this is Shiv and Shivani. They're siblings from Delhi. Both came to me pre-COVID in 2019 as a 2-year-old and a 5-year-old. They had a family history of myopia in both the parents. So parental myopia was there. Mom had about -2 diopters and had Lasik for her vision, and dad still wore a -1.5 diopter glass prescription. So 2019-18, since both the parents had myopia and they were quite aware of recent developments in myopia progression and wanted my opinion on whether the kids had any tendency for myopia. Both of them, I had taken them for a complete comprehensive checkup. I had done the axial length estimation. I got all the data I wanted to so that I was prepared. And those days I used to decide, I'm going to wait and watch before, if there's progression in the axial length, I'll go and then treat it or put them. So first thing I spoke about was parental myopia and lifestyle modifications. So parental myopia, there are in fact a lot of publications which speak about the validity of parental myopia. I like to give figures to the parents to just rattle them a little bit so that they take it a little more seriously. But you have to be very, I would say, sincere with what you suggest thereafter, and also very careful. You don't want to overstep and break hearts at the same time. So it's very important you speak to them what the literature says. And we do know one parent versus two parents, the chances are more. We also speak about lifestyle modifications to the parents and the children, and they were advised, these kids rightly were advised in 2018-19 about lifestyle modifications, going out more often and follow up with us more often, and we'll be repeating the axial length to make sure that myopia doesn't progress, and keep their screen minimal. But then what happened next was unprecedented. We all underwent COVID-19 and the lockdown effect. So pre-COVID, we were telling all the parents and kids and teachers that they have to increase their outdoor activities, they have to go green, nature and nurture, reduce the screen time, increase reading distances, avoid dim light exposure, you need UV, and there was vitamin D theory also going around, which spoke about how that was important for myopia. And post-COVID, what happened was we increased their indoor activities. They had nowhere to go. They had go screen rather than go green. Online classes to online games were going out of hand. Increased screen time, reading distances were more than 30 centimeters. They couldn't avoid any dim light exposure, and no sun and sunlight was happening. So we do know that screen time versus health had not only the eyes which had problems, they had mental behavior issues, stress, anxiety, loss of social skills in these kids, behavioral changes, and also cognitive development was affected. It also had a disturbed sleep pattern for these kids, and it started becoming a habit forming. Because remember, all these kids are young, and COVID caught them early. So there was change in habit forming and reduction in attention span. A lot of articles came out during that time speaking about what you should do, what you not do, how do we improve the situation. And this is what we told the parents who got in touch with us through tele-ophthalmology, that fight screens, fight the environmental factors. Some tips we gave them was large screens, more distances, keep the room well lit, 20-20 rule, optimize font size, brightness of the screen, avoid recreational TV wing. Some stuff that I still recommend to all children. So what happened in 2021, schools opened, quarantine myopia had stuck. So both Krish and Shivani, both of them came with complaints of unable to see their smart boards in school. So the axillary was done, cycloplegic refraction was done, and both had become moderate myopes, minus 2.5 to minus 3.25 respectively. And the retina IO was absolutely normal. So these are the options we have whenever we talk about non-surgical myopia progression treatments. We have to lifestyle changes. We warrant right spectacles, never undercorrect or overcorrect, try to get it perfect. Contact lenses and an option. Orthokeratology has been spoken for, but again, it's invasive and most ophthalmologists feel a little uncomfortable with orthokeratology today. Pharmacological interventions are available. So that's atropine that we talk about, which is readily available in our market, and percentage, of course, is a point of discussion still. So what method to choose? We had pharmacological therapy, we had spectacle-based therapy, and contact lenses. So pharmacological therapy has been most effective, most widely used. Side effects were minimal. Long-term effect of mydriasis cycloplegia is almost negligible with 0.01%, which is available in India, and 0.05, which is available in Europe. Spectacle based, we spoke about glasses all the time. We incorporated cylindrical prisms. There was talk about progressive lenses, bifocals, which also have been tried and tested. Orthokeratology, as far as contact lenses, and also multifocal contact lenses have been spoken about. So we had different medications. When we talk about this, we have atropine, benzodiazepine, out of which atropine has been the most widely used. So what they basically do is they retard the axillary elongation by affecting the release of dopamine and synthesis of GAG in the sclera. And this itself reduces the axillary elongation and thereby reduces the progression of myopia. So in short, we had drops, the ATOM study, which spoke about how this works beautifully in Asian children. And we've carried it forward to our Indian studies, which have also spoken about it in the IGO, and is fairly a good way of treating and controlling progression of myopia. So what happened with the first child? Krish, the elder one, stabilized with these interventions. But his sister, Shivani, who was younger and faster developing, more myopia, progressed despite these changes. Now, remember, these kids are getting myopia much earlier than it was documented for the previous generation. And that means they're going to develop a higher myopia. And that's what we are fighting. So we decided to offer the parents an option to add another management option. So there were bifocals and PALs, which were spoken about, and newer spectacles of myopia progression like HALT or DIMS technology and orthokeratology. So bifocals and PALs, there have been a lot of studies, and what we have seen that PALs have low efficacy. 20 years ago, a study suggested that progressive addition of spectacle lenses slowed myopia by 0.5% for over 2 years. Unfortunately, this was another study of 3 randomized clinical trials said it really doesn't work so well, and that had about 800 children, so we have to listen to it. This is another COMET evaluation, which largest found a 3-year reduction in progression of 0.2 diopters with PALs compared to single vision glasses. So definitely it was better than giving single vision glasses. And also virtually all the effect was observed in the first year. So it affects fast. The trial was repeated in myopic children in the COMET-2 study with higher accommodative lag and esophoria, and the mean 3-year treatment benefits of PAL was less than 0.3 diopters. Like the original COMET, this was also slightly clinically unimportant. There were a lot of meta-analysis which spoke about this. So what do these special glasses do? So there's something called peripheral. Wait, let me get that. All right. Okay, I'll try and show video later. My video doesn't seem to be working. All right. So we have the Zeiss Myokids and the Myosite. So basically what these classes do, they have for reading, they've added a plus so that it encompasses a myopic defocus. Thereby, in the peripheral diffractive theory, what basically happens is the eyeballs start elongating because of the peripheral rays which go beyond the retina, thereby giving a precursor for the retina to grow and try to catch that peripheral ray as well. So by adding a myopic defocus, we ensure that the eye does not elongate. I'll try and show a video because it's a little easier for everybody to understand otherwise. And this has been spoken about. Sadly, the Zeiss Myovision and Myovision Pro glasses did not really hit it off so well with most of us. Because the design of this was either in the periphery or right in the side of the center, making it slightly difficult to monitor and slightly difficult for it to be more effective. Yes, of course, orthokeratology was an option. This did a similar peripheral diffractive theory where by putting contact lenses, it flattened the sides, giving a myopic defocus sort of a picture. So this is what happened with Krish, and this is what happened with Shivani. So after we put on the DIMS technology, she responded much better. So we needed 2 rather than 1 management options for her, and her myopia was controlled thereafter, but it took time. And in the meantime, her myopia did progress. So DIMS, this is how the lens of the DIMS look. If you can see, it's a honeycomb structure. The central clear part gives clear vision, which is required by the child. And then you can see those small islets of plus 3.5 positive segments, which work in producing the myopic focus for the periphery and thereby reducing the progression of myopia. We also have the HALT technology, which again, the video is not working. So the HALT technology comes with a similar structure, but it's more dispersed. So amongst both of them, DIMS and HALT both work very well. And a lot of studies speak about both being comparable in their current scenario. Of course, we need more literature because they've both been there for about a year in our practice, but seem to be a good second option for myopia progression. So now meet the siblings in 2023, and they're much more controlled and happier. Another thing, what we noticed was missing out. So this was Aryan. He was a 9-year-old boy who loves to read for long hours. Now we know near work also has a potential of increasing myopia progression. There was no parental myopia with him. He had documentations for previous eye checks from his grandparents' town. Vision was 6.6 N6, and he had a refraction of 0.5 SIL and 0.25 SIL in both the eyes. So he's a 9-year-old boy, loves to read. Again, a good chance of having myopia. So in 2020, he came again after the first wave, and suddenly this had progressed to 3.75. And that itself is alarming. And at this onset, the axial length was 25.65 and 25.53. We documented that. We had also exophoria, which was noted, and accommodation amplitudes of 12 diopters. So what we did next was we started him on treatment, and we started him on pharmacological therapy. And this was going well. And then suddenly the second wave and lockdown happened. And when this happened, Aryan was out of medications. He was still reading, and that caused online classes and everything caused a potential increase in his axial length. And when he finally came back to us, he had sudden progression of myopia. And beyond that, we had decided on myopia glasses with DIMS with twice a day atropine instead of once a day atropine, with no complaints of photophobia. And then we sort of managed to control it. And subsequent visit, this has been another option that we have been doing. If we have time, I'd love to show a video, but I think I've overshot my time. Have I?
Thank you so much.
Yeah.
You can
Thank you so
go ahead
much.
and show the video. You can show the video.
Should I?
Yeah. Go ahead.
Right. So just to put perspective, can you see my slides? Is the
Yes.
video? All right. So okay. So this is a small video. So we know that myopia is basically elongation of the eyes, and that causes most of the problems. So there are various theories we talk about. I want to talk about peripheral defocus theory. it's more visual, so I would love to show this video. That's what I want to do. So we've noticed the peripheral rays at the sides that goes beyond the retina, and that causes the axial length to increase. So that causes biochemical signals, that causes the eye to become longer and longer, even though you're correcting to the complete target as far as the central retina is concerned. So there were a lot of researches they spoke about, and they spoke about. So basically, there were several new glasses that came out, the DIMS and the HALT. And what basically this did was, in the periphery, it caused a myopic defocus. Basically, get the blue dots in front, and that counteracted the axial elongation, and we found that that was helping with myopia progression. So of course, bifocals and progressives did the same when the child was reading, caused a myopic defocus, and thereby worked beautifully. And of course, contact lenses did a better job because they moved with the eye rather than the eye peeking up and down. So that's how they worked. Excellent. I think over to you guys.
Great. So, there's lots of query and there's lots of interest that has been shown for these Ortho K lenses. We're not so much in favor of it. We're not taught about it so much also during our post-graduation days. But, there are some people who give them just offhand, and there are some people who really benefit. So just for the benefit of the general audience, could you please elaborate a little more on the Ortho K lenses?
So Ortho K lenses, basically, by putting them overnight, they change the surface of the cornea, the shape of the surface of the cornea, and they do the same thing as the peripheral defocus theory. By basically flattening on the sides, they cause a myopic defocus in the periphery. And that's why they stop the axial length elongation and temporarily correct the small myopia that you may have. And they work very well. It's just that we are a little more scared of giving contact lenses in children. But there are a lot of Ortho K trained specialists, optometrists to do it. And I think it's not a bad idea. It's a good armamentarium to have. But I usually go with non-invasive towards invasive rather than the other way around. So that's been my practice. And that's
how long does that change of shape last for?
It's supposed to be overnight. So you put it overnight, and the next day it's supposed to be working beautifully.
Okay, and then again, so you can repeat it every day.
Yes. So yeah, but the theory is the same. Peripheral defocus theory works here as well.
Okay.
So, but the point being is not one is as effective. It's a good combination to have with another. So you may want to put atropine along with Ortho K in non-responsive pharmacological.
And how liberal are you in your practice with atropine?
So a lot of factors come into it. The first factor is parental myopia. If the parents are aware about atropine, because counseling is a very important part of any practice. And here again, that's repeated when you're talking about children. I like to get axial lengths at a span of 3 months to 6 months and document progression before I start. There have been a few cases where I've been more aggressive and started earlier. Those have been like the kid you saw. He came to me, there was no axial length done. And then after first wave, there was suddenly -3. So there I would have started a little earlier. So it's best to have documentation before you start any medication, and atropine comes in the same pattern. Yeah.
Okay.
If I can ask a question.
Please.
So I see a lot of people, a lot of children come to me. First time they were detected, let's say 2.5 myopia. And just because now ophthalmologists have heard of atropine, they are straight away put on atropine without any documentation of axial length or a progression. So what's your view? Would you start on a first visit? Let's say somebody gets detected with a -4 on the first visit. Would you still put him on atropine or watch for progression?
So, ma'am, atropine is basically treatment for progression of myopia. So, till there's no documentation of progression, it will be useless. But coming again to real life scenarios, if there is parental myopia, I may take the plunge. But if there is no parental myopia or awareness, I will still, suggest lifestyle changes and review in 3 months. No axial length change, then I will go ahead.
Okay.
If I can add to this, hi, I'm Pooja.
Hi.
Yeah, I think we should wait for the progression. And if we are concerned about, say, it was a -4 myopia already, keep a shorter first follow-up, document the progression, and only then, start with any therapy. So I think that should definitely be the take-home message.
Before we move ahead to the next speaker, ma'am, there's a question from the audience for Dr. Vaishali. How do you handle progression of myopia in those patients who you do phakic IOLs, say after 2 to 3 years?
So yeah, that's a very valid point. So the number one thing is prevent. So therefore, like I said, for me, the cutoff is going higher and higher. And I do want to see, like if I get somebody on first visit, and if they have a good documentation of at least 1 year stability, I will advise on that visit. Otherwise, I'll ask them to come at least in 5 to 6 months. So first is see for yourself that there is stability. But there will be patients, particularly pathologic myopes, whom you put an phakic IOL and they will progress. So the best part is counseling, and whether they are progressive or not, any high myope, I would always say that the aim of refractive surgery is to give you good functional vision and not zero myopia. Also, in high myopes, we are aiming at debulking your refraction. We never say that you may need a pair of glasses for driving or fine work, but that will be much less as compared to what you were using. So I think we do need to counsel them. And the point that Aditya brought up, that's why preoperative biometry, if you have, and if you can show a change in biometry post-op when they come up with the myopia, it's actually good to show them these two scans and discuss that, yeah, I mean, your eye is a little unusual in the fact that it's still progressed in axial length, and therefore it's okay to wear a pair of glasses or contact lenses for an SOS use. So I think we as surgeons should not shy away or should not feel sort of as if it's guilty if the patient has a progression. Talking to them and the family in multiple visits usually does the trick. And preoperatively always tell them that you are debulking their myopia and not eliminating their myopia.
Correct. So just one more thing, what's your cutoff age minimum for putting in an ICL?
So at 20 complete. So practically 21-ish is the cutoff.
Okay.
And if I may, we'll be seeing more and more of phakic IOLs in practice because myopia is happening much earlier now. So if a child who's 3 years old is getting myopia now, the rate of progression being 0.5 or 1, they have a higher chance of having a higher minus. So these questions and these progressions post 18 may also happen. So I think documentation and counseling, right? It's mostly doctor's guilt which gets you because we counsel for being zero, glass free. Those are not the right way to counsel any patient, even a parent for that matter, when you're talking about progression of myopia. It's not always in your hands, and that's why there's so many other methods of correcting myopia and stopping progression.
So between 18 and 21, ICL is out. Is the panel, absolutely certain on that? Between 18 and 21, we should not be putting ICLs?
I think
don't think so. I mean, unless
I agree.
One exception would be somebody who is a astigmatic or a low to moderate myope, where you are putting in ICL because their cornea was not suitable or they don't want a corneal based procedure. Then maybe 19, 20, fine. But for a high myope, for me, Kareeshma, what's your opinion?
I totally agree. And I think along with Vaishali, there's a lot of us, there's a wave of us whose age for cutoff criteria, not only for ICL, but even for Lasik is becoming more and more tight. And because the ideal way to go about it is, as the other speakers also mentioned, is that you want to first wait for the patient to be in a completely progression-free zone. And how do you know that they're not going to progress between 18 to 21? So even though in Lasik also the FDA approval is for 18 years of age, but we kind of in the counseling, I have also started now telling them that, we might want to consider waiting for some more time, observe you. You've already waited 18 years. Why don't we wait some more time? To kind of convince them that maybe waiting longer will prove to us that you have gone into the entirely stable zone before treating it.
I agree with you. In fact, if I can just share a story that happened a couple of days back, even though I'm like the least experienced here, the youngest in this group, I got a call from a consumer foreign judge who's known to the family just 2 days ago. And there was a 19-year-old who got operated for Lasik somewhere. And she was a -9. And now post-correction, she's a -4. And she has put a case in the consumer court. Now, the judge was asking who's at fault here. Now, the thing here is, of course, there were lots of sort of parameters to look at in that particular case. But what he told me was that, you know why this doctor is in a soup? This doctor is in a soup because he has advertised outside his clinic that post LASIK you'll be spectacle free. He's not written if you're a -9 or a -10, then there will be a residual number that will be left behind. He said, so that is something that maybe we can sort of look at, especially when advertising. He said it's not the science that's getting this doctor into trouble, it's the advertisement that has got the doctor into trouble.
All refractive surgery is good counseling. Everything, even cataract, getting your zeros, whatever, it's good counseling. And in the future, I feel video counseling will be the way to go. But if you don't want to be in that situation.
Also, does anyone suggest refractive lens exchange for of course, a little higher age group patient, 30 above or something? If it's a high myope, do you prefer LASIK or ICL, or do you even give the option of refractive lens exchange?
I think RLE is a last resort because high myopes, you have tendency of having RD also, and it's been documented that if you do RLE earlier, the chance of RD is almost double or triple. So RLE is last resort. If they're very motivated, yes, that can be an option, but last resort.
Yeah, I think personally for me, anybody below the age of 50, I will actively try not only to not counsel them, but dissuade them from getting an RLE anywhere. So I'm not going to do an RLE except if it's a very exceptional situation.
Yeah, hypermetropia, yes. Myopia, I would be very skeptical.
Okay, we move on to our next speaker, who is Dr. Kareeshma Wadia, a very well-known cornea specialist in Mumbai. She has done a fellowship in cornea refractive surgery from Narayan Nethralaya, Bangalore. Currently, the director of Jehan Eye Clinic, Mumbai. Dr. Kareeshma is here with us to talk to us on LASIK in myopia. Over to you, Dr. Wadia.
Hi, I'm just setting up my screen show. Yeah, is my slide visible?
Yes.
Yes. Good evening, everybody. Thank you so much for inviting me to give this talk. I'm going to be talking about the corneal aspect of the refractive surgery for myopia, which is basically LASIK. Now, I'm glad that we had this discussion right before my talk, because that's my opening slide. What is the one factor that defines the outcome of your refractive surgery? Your pre-LASIK screening as well as your counseling. So basically that would be a part of the entire process, because once you have gotten that right and gotten your facts straight with the patient, where you don't guilt trip yourself, but from the beginning you have explained the science to the patient, the fact that the healing of the eye is going to have an outcome which you cannot predict for sure. You might have a 0.5 minus or plus. That's how I always put it, to kind of explain to them that there's nothing as a perfect zero and you always may have some residue. Like Dr. Vaishali said, to tell them that we are debulking your number and you might be left with a residue of something, but that constitutes what we call within normal limits. So when you're looking at the patient profile, you not only have to look at your age, but you also need to look at the occupation, their visual requirements, and very important, what we often tend to miss, because we assume that they are young and they may not have any other systemic issues, but a lot of them, particularly in this age group, will have systemic issues like acne or acne rosacea, which is going to have an outcome which is going to affect the outcome of your surgery. So the most important, I think, in your patient profile would be a motivated patient. I'm a slightly conservative LASIK surgeon, so I'm not the one who, I always tell the patient, I'm not going to advise you the surgery until you ask for it from me. And only after I have made sure that all your tests or evaluations give me a green signal, only then are we going to go ahead. If anything is in the gray zone, we're going to step back. So your must-dos, like we just mentioned, the patient needs to be fully informed about everything. The age, 18 years is what it is on paper by the FDA approval, but as mentioned below, current FDA approval is for myopia up to even -12 diopters. But practically speaking, we don't want to do it for refractions above -8 or -9. And I look for a stable, documented refraction being stable for at least 1 year. So if I'm seeing the patient for the first time and they have no previous records, I would still advise them to wait for some time longer. And as I mentioned, I try to demotivate them for a little more than 18, edging towards 20 to 21 years of age. It's very important that you know your patient and their expectations, particularly the patients who are in their late 30s who are coming to you for LASIK. They have no idea of how presbyopia is going to hit them. And then later on, there may be disappointments when presbyopia hits. So it's important that you explain all of this to your patient. What do we check? Apart from visual acuity and refraction, you check for dry eye status, you check for your topography and pachymetry, your abrometry. Pupillometry is important because you may have some night vision issues for people whose pupils are larger than normal. And I always do an IOP and a comprehensive retina checkup for everybody, whether it's a low myope, whether it is a moderate myope, whatever level of myopia they are. Okay. Vision and refraction, apart from your autoref readings, it's important to also do a cycloplegic refraction for these patients. Ideally, you do cycloplegic, but in practical life, we are normally dilating them with tropical, and we can do a dilated refraction. A lot of institutes do a wave scan guided refraction as well, which gives you an even better idea of their astigmatic correction. Of course, we all know that a Scheimpflug imaging with topography and pachymetry would be the ideal way to assess them preoperatively. You also do an abrometry with the abrometer available to you. Clinical examination for all of the things that we've already mentioned. Coming to this part, which a lot of people take for granted, dry eye assessment is now very important as a part of your any refractive surgery procedure, not just a regular Schirmer's. You need to do a Schirmer's test too, which is the Schirmer's with anesthesia. And to check your T-butt. I'm of the opinion that if you feel that the Schirmer's is borderline, or if the patient has a poor T-butt, you can advise the patient lubricating eye drops, get them up to a certain level, let their T-butt improve, let them get better, and only then post them for surgery. So what I always put it across to the patient is as that you have waited all these years. Now we'll just wait for another 2 to 3 weeks, let this stabilize, get a little better, and then we'll operate on it. In the dry assessment, as mentioned by the previous speaker, we don't need any fancy assessments. You can just check with your normal slit lamp for blepharitis and MGD, press onto the glands, and make sure that the glands are expressing a good amount of secretion of healthy quality. This is the lid margin assessment. Make sure that you have no underlying blepharitis or MGD before you operate, because these are the patients who will not only have a good pre-op assessment, which will affect your outcome, but also they are the ones who will be more uncomfortable symptomatically. And they are the ones who will come to you even with 6/6 vision, but complaining of something pricking in the eye and irritating the eye. So they are more upset about those symptoms. Post-operatively, what do we want? Obviously, we all want emetropia, but more than that, we want a residual stromal bed of more than 300 microns. Now, again, this value varies across surgeons and their opinions. A lot of people go up to 275 or 280 microns. This is a personal cutoff that I choose. And there's also the amount of ablation that you go up to. So I do not like to cross an ablation of 100 microns, even if my residual stromal bed is good. I don't like to cross an ablation of more than 100 microns, unless, you know, by going to 110, I'm completely eliminating the refractive error or some such. Otherwise, I like to stick to an ablation of 100 microns. That's because I don't want to induce too many aberrations, and I want to have a smooth stromal bed with minimal dry eyes. So what are our red flags? We already mentioned about the residual stromal bed. We want to make sure that there are no flap morphological changes. So ideally speaking, we would want to do a femtosecond for everybody, but it may not be possible. Keratometries, very steep or very flat corneas, you have to be wary about them. You need to also explain to these extreme keratometry values patients that they are the ones who ideally need the femtosecond LASIK. So you want to directly push them for this. And of course, these are very radical values. We don't usually want to treat them. High aberrations is something that you want to watch out for. Again, you might want to consider abrometry guided LASIK, and always watch out for a refractive surprise, for which you need to make sure that you've done a good dilated refraction and you've made sure that you've eliminated dry eye before doing all their analysis. Of course, the absolute contraindications are a must-know: active infections, ectasia, glaucoma, cataract are things that we're not going to operate in. Things to watch for are, apart from your MGD, when you're looking at your patient and talking to them, you can already assess the nature of their skin, whether there's a lot of facial acne. You can also ask the patient for any history of oral intake of isotretinoin, because this is the drug that's going to produce atrophic MGD, which will not crop up symptomatically until you have actually hit them with the trigger, which is your own LASIK surgery. So they will start suffering from symptoms only after the surgery and blame you for that. You also want to keep a watch for their brow area. A prominent brow or a small palpebral aperture will be what is going to make you face a lot of difficulties, especially if you're planning for a microkeratome LASIK. And lastly, any signs of keloidal tendencies. Amongst other things, you also ask the patient for history of polycystic ovaries, thyroid, anything else that can affect your outcome in terms of symptomatic treatment. So when we talk about lasers, there was an evolution all along. We started with PRK, like Dr. Himanshu mentioned, and then we went on to microkeratome LASIK. Then there is femtosecond LASIK, then there was Flex, and then there's Relax Smile. So when you talk about microkeratomes, there are different modalities of microkeratome pass in the LASIK. There are rotating or pivoting flap creators. There are linear flap creators. Linear ones are the easiest to use, like the SBK Moria or the Amadeus, which is very simple to use for the doctor, for the surgeon, especially for a novice. It's just to be held onto the eye and there's a horizontal movement. The rotating ones are slightly more tricky for beginners. The head, again, can be vertical or horizontal based on the type of movement that it's having, rotational or linear. Then came the femto revolution. So in the femto revolution, what we need to understand is the way the femtosecond laser actually does its job. So femtosecond laser is doing photo disruption so that it can create our flap for us. And then our excimer is doing the actual tissue ablation. So there's a two-step process over here. And what is Relax now when you bring that into the picture, because that is also femtosecond laser. So that's, of course, brought from the Visumax femtosecond laser, was the first establishment. This is known to provide correction of myopia for less than 10 diopters. Again, there are varied opinions on the maximum amount that you might want to treat on SMILE with this. But basically, it's a stromal lenticule being cut within the stroma and then has to be removed. What that does is allows you to dissect manually once the cut is made. Now, in the femtosecond, when you are actually doing photo disruption, how does that happen? It's because of the creation of gas bubbles, which disrupt your corneal stroma or your lens material based on what you're using it for. There's a high density of photons that are released. The energy is absorbed in the molecule in the form of plasma, which expands ultimately and releases in the form of a gas bubble, which is why you also have a kind of a venting canal when you make your femtosecond flaps. So in your photo disruption, there are thousands of laser pulses that are all being connected to each other to define one particular plane at which your LASIK flap will be created. And this can be customized as per your corneal flap diameter, the hinge angle, the depth of the flap, so on and so forth. So the advantage that it gives you over a microkeratome LASIK would, of course, be the most important thing that you can play around with is your flap thickness, particularly for high myopes, where you want to conserve more cornea so that you can ablate a little more. So you can play around with your flap thickness. What is better, SMILE or LASIK? There are multiple opinions about this as well, but let's look at a few studies. In refractive outcomes wise, they are both shown to have similar refractive outcomes. However, if you look at other issues, of course, we all know the flap-related complications that come with any sort of flap-related LASIK, whether it's striae, ectasia, epithelial ingrowths, flap dislocation, or DLK, which would be more with flap-based procedures as opposed to SMILE. Since in SMILE, the amount of corneal nerves damaged is less. So again, the incidence of dry eye and the comfort of the incidence of dry eye is lesser and the comfort is much more. Higher order aberrations, also the studies show that there was no statistically significant difference in both these procedures, LASIK or SMILE. But there definitely has been shown, better corneal biomechanics when you're doing a SMILE. So what do you do, LASIK or SMILE? We'll talk about that in the discussion part. Just before concluding, here's a small video or animated video about how the femtosecond LASIK takes place. And that's about it. Once your flap is lifted, then you can go ahead with your ablation. Thank you very much. And before I conclude, I'd like to put this question across to my panelists. What is it that you prefer in this day and age? Would you still go ahead with your femtosecond LASIK, or you'd offer your patients a smile?
I think there's room for everything.
There's room for whatever you have, yeah, whatever you've invested in, or for a person like me who's not invested, whatever is closer by.
Yeah. Because I think it also works patient to patient. Like both procedures work in certain situations slightly better than the other. So yes, space for both. Yeah.
Right. Thank you very much.
Ma'am, your thoughts? What would you prefer, a patient to have smile or LASIK?
I'm a big fan of LASIK, so I'm like biased towards LASIK. Very personal reasons. So if the patient asks me upfront for a smile, then I will do a smile for them. But I'm very biased towards a femtosecond LASIK.
And Vaishali ma'am, your thoughts?
Yeah, I think I agree with Kareeshma. I don't have access to a smile, so anyway, I do a LASIK. But yeah, I think today I find the LASIK much better in certain parameters because of its time-testedness. So yeah, but I think it really depends on what you are comfortable with and what is accessible to you.
And LASIK or Contoura LASIK as the sensation across the country.
I think let's keep it at the fact that it is sensational as of now. So it's working well for everybody.
Pooja, what about you? Are you for LASIK or not?
I think I'm for LASIK.
Why?
What about your thoughts, sir? What would you choose, LASIK or smile?
Well, biased toward LASIK because you have a machine. Finally, they have proved that LASIK and they have proved that smile and LASIK have equal complications. And as more and more studies come out, you will find that people who are unhappy with monofocal, multifocal, trifocal, people are going to be unhappy with everything. Whatever you are happy and comfortable and you got results is the best thing that is going to work for you. So PRK safest, whenever in doubt, PRK. Simple. That's
Absolutely.
it.
So there's one question that is there, that 18-year-old walks in, first time coming in for a consultation, a -3. Would you wait for 6 months or would you go ahead and do the LASIK surgery?
Would depend on whether they have any previous records. So if they have established, documented, a lot of our generation is now documenting very nicely. So if they have records of us showing that for the previous 1 year it's been stable, then it would be okay. Again, I would try to push them around for.
If they don't.
If they don't have any record of being stable, I will make them wait.
You will make them wait.
100%.
Rohan, I'll ask them a simple question. Like, Rohan, how old are your glasses? When did you last change them? When did you last change them, Rohan?
2 years ago.
Can you see through them?
Yes.
Can you see everything?
Yes.
Are you missing out anything?
No.
Okay, I guess that's the answer. I don't need records. I need your eyesight. And if you can see
So,
20/20 with
so
your
their glasses
right?
would have to be stable as per whatever we are checking them on date.
Yeah. Okay.
So we move on to our last talk, and the most important aspect, non-surgical approach to myopia control. We have with us a pediatric ophthalmologist, Dr. Pooja Gogri, another alumnus from Narayan Nethralaya, Bangalore. She is the director of Jyotirmay Eye Clinic, a pediatric ophthalmology center with oculomotor and nystagmus laboratory in Mumbai. She has been working closely with myopia and will be talking to us on the non-surgical approach to myopia control. Over to you.
Thank you so much for having me here. and the kind introduction. Just going to start sharing my slides. A lot of my work has been. You all can see my screen, right?
Yes.
Yes. A lot of things have been nicely spoken about by Dr. Sethi. I'm just going to stress on a few things again. So as the topic goes, it's non-surgical management of myopia control. And what I want all of us to just be sure of is what exactly are we trying to deal with when we're talking about myopia control? It is the higher myopia, which increases this exponential risk of complications like retinal detachment and myopic maculopathy at higher powers. So keeping it lower is better, and which is what we want to aim at. And if we were to look at all our strategies, strategies include lifestyle, optical, pharmacological, and combined. And the reason I've chosen this PPT is, which is very bright, colorful, and outdoory, is because I want to stress on the fact of lifestyle being extremely important. And the current recommendations actually would be 2 hours of outdoor activity. What is important is it should be in daylight. Most of the kids, if you ask the history, they go out to play at 6:30 or 7 in the evening, and they probably go out for an hour. So they definitely don't get the 2 hours of daylight. And why is this important is because the luminance or the lux is important in prevention of myopia setting in, as well as in the role of controlling myopia. Now, this is something that I've incorporated in the history taking. So many times I ask them, what is your outdoor activity like? They'll say 2 hours a day or 1 hour a day. If they say 1 hour a day, I'll ask them, what time do you go out? So that we can correct that. Coming to the screen time reduction, of course, we all know screen time reduction is good, but basically less of the time further away the screen and the larger the screen, the better it is. And why is this important? Because it has been studied that 14 hours of outdoor activity in a week can reduce the parental risk factor that the child has on him developing myopia. So we can almost negate the parental risk factor if we just incorporate some lifestyle changes so that environmental modifications help reducing the genetic risk factor. So I want to reiterate, history and reinforcement at each visit remains important, which means that even if you're starting any other therapy, we must continue reinforcing this. Coming to the optical therapies. So when we talk about optical therapies, the entire thing is based upon peripheral refraction, okay? And the reason that is that if we look at this uncorrected myope, this first diagram, what it shows is that, of course, the rays of light are focusing in front of the retina. Now, the traditional correction corrects the eye at the macula. However, if we look at what is getting corrected in the periphery is going beyond our globe and the retina. Now, technically, what should be the optical correction? It is hypothesized that it is the peripheral retina which also plays a significant role in progression of myopia, which was studied by basically by ablating a monkey and a chick, where the macula is ablated, and you see that they still continue to progress. And why is that happening? That's because the peripheral retina is playing a role in myopia progression. So the newer lenses that are out are basically aiming at this technology where they have certain lenslets. So they have a central area which is clear, which aims to target our clear vision in the center, which is going to help focus on the macula, the fovea. So this is our foveal centration, which is as per our myopic refraction. Now comes the peripheral lenslets. They have different designs based on the companies that are different, that are out. Either it is the DIMS technology or the Holt technology. And both of these have been widely studied over 2 years plus study for a randomized controlled trial. And they both have had almost equal. Holt technology slightly better than the DIMS technology. And what they do is these peripheral lenslets have a hyperopic correction in them, and they are interspaced by the normal correction. And what that means is from the periphery, the rays are falling in front of the retina, not exactly at the retina. So it forms either a volume of defocus or a plane of defocus. Now, what is very important when we look at these patients is that we must make sure that the central area is aligning with our central pupil. And in the IPD is perfectly marked, the size of the frame is perfect for the child, and the lens is dispensed only after that. Often what we see is some children are dispensed these glasses and they'll be seeing either over or above this pupillary clear plane, which has to be seen. So they see blur. So in whom do we prescribe these glasses? Either it can be used as a first line of treatment, second line of treatment, or a combined treatment. That means an additive treatment. And as a first line of treatment, we may use it in children who have a relative peripheral hyperopic defocus, which can be checked on a peripheral retinoscopy or an open field ARR. Progressive myopes who are not willing to use drops. So a lot of parents complain or are very hesitant to start using drops when you tell them that you're going to have to use this for 2 years. Or progressive myopes who are not cooperative to use drops. And if there is any relative contraindication of using atropine drops. Now, as a second line of treatment, we can use it in patients who are non-compliant to the atropine drops or who have an allergy to atropine drops or have developed some adverse effect like photosensitivity or near vision issues when we stepped up the atropine drops. So peripheral defocus glasses should not be used in certain cases where cost is a factor because it is expensive. It is close to 15,000 to 17,000 rupees a pair. Maintenance can be a challenge. Since each time the expense is quite big, you have to make sure that they can maintain the glasses well, and limitation of the refractive error. So most of these lenses have an upper end beyond which they cannot prescribe, they cannot make these glasses. So it's close to -10 as an MRSE or a 4 diopter cylinder that they use. Coming to the next part in optical, which is Ortho K lenses. So we were discussing how does Ortho K work. So Ortho K similarly works on the principle of peripheral defocus, where you use a contact lens overnight, and what it does is it flattens the central portion and it steepens the peripheral portion. And when you wake up in the morning, you remove the contact lens, you spend the day without any refractive correction in place. This was originally out basically to keep people spectacle free through the day. However, it was also noted that it is helping in controlling the myopia progression. And this is the AO report, wherein axial length elongation reduced over by 50% over a 2-year study period. Younger age groups and children with a larger average pupil size may have a greater effect with Ortho K. Rebound can happen even after you discontinue or you change to an alternative refractive treatment. However, safety remains a concern because of the risk of potential blinding microbial keratitis from the contact lens wear, and which is what our main concern is. I personally do not practice Ortho K unless it is demanded by the patient. It does require a lot of counseling and a very good training to dispense these Ortho K lenses. So they better be dispensed and monitored by people who are trained in it. Coming to this wonder drug, the pharmacologic treatment, which is with low dose atropine, either used in the strength of 0.01% at bedtime or twice in a day, or 0.05%, which is reconstituted currently in India and is in study phase in India. However, it's available in certain parts of the world. And where I'm going to take you through a few cases to know where we can use this drop and where we should not be using this drop. So if the case one is this 14-month-old child who has history of holding the toys close to face, and on atropine refraction, we see a very high myopia of -10 to -10.5. We follow this patient up at 36 months of age and the refraction is the same. Now, this is a case of congenital high myopia that is not progressing. So this is not a case that needs to be on atropine at all. Coming to the second case, a 10-year-old child who has a cycloplegic refraction of -5 in the right eye with a vision of 6/18 and left eye improving to 6/24 BCVA with a -5.5 diopter sphere. He has some history of photophobia on follow-up at 1 year later. There is a small progression in the left eye of 1 diopter, but the fundus shows early mottling and the ERG suggestive of some rod cone dystrophy. Now, any retinal dystrophy is a contraindication for using atropine drops and it is not approved. Hence, we cannot prescribe atropine drops to these patients who have any retinal dystrophy, even if there is any progression in myopia. Child 3 is a 12-year-old boy with a history of allergy, where we see the cycloplegic refraction of -3 sphere with a -4 cylinder, improving to 6/9 in the right eye and improving to 6/9 in the left eye with a cylinder, compound myopic astigmatism. Now, 1 year later on follow-up, we see that the cylinders have increased in both the eyes. So the MRSE has actually increased in the right eye by 1.5 diopter and in the left eye only by 0.25. But the retinoscopy shows a Caesar's reflex. So this is a case of a keratoconus or a keratoconus suspect. This is not the child where you can use atropine drops, even though there is an increase in the MRSE. Now, the last case is a 10-year-old girl with a cycloplegic refraction of -3 diopters in the right eye and 3.5 diopters with a 0.5 cylinder in the left eye, improving to 6.6 in both eyes. And 1 year later, we do a cycloplegic refraction, showing a progression in both the eyes by about a diopter. Both eyes fundus is within normal limit. Now, this is the classic case of simple myopia, which is progressing. And this is the child who should be started on atropine drops. Now, clearing this, indications for myopia, atropine therapy in myopia progression is axial myopia. So in this previous case that we last discussed, we should have done an axial length, followed it up with an axial length so that we confirm that it's an axial myopia, not an congenital or pathological or curvatural or a lenticular myopia. So the SNEC, which is the Singapore National Eye Center group, proposed based on, so there are some landmark studies that have happened on atropine use, which is why atropine has become so popular in India. And they all, if you go through it, they've all documented what should be the treatment based on the amount of progression. So I want to reiterate that it is always defined by how much is the progression. So atropine is used for progression, and how much to use is also defined by the amount it progresses. That means if it progresses more than 0.5 diopters in a year is when you call it a progression in the first case. So good response is when you have a progression on atropine of less than 0.25 diopters in 6 months, or if you have 0.25 to 0.75 diopters, it is called a moderate progression. And if you have more than 0.75 diopters, it's called a poor response. And we can assume sometimes that these poor responders can be non-responders. So what we have to understand is not every child responds to atropine therapy. There is a 20% population that will not respond to atropine therapy, and they're non-responders to atropine. So the pharmacological treatment, if you had to take home any message, even if you're sleepy, it's that it is only for progression. It is only for axial myopia. So axial length document is important. It is very important that you make sure that progression is confirmed after cycloplegia only. Counsel well, because it is going to require long-term therapy and compliance with the patient. So I always tell the parents that they're going to start the treatment minimum for 2 years, and it may even take longer, depending on the age of the child. Reinforce lifestyle at every visit and follow up regularly to look for any adverse effects. Now, what are the adverse effects with atropine? Photophobia, allergy. Check the near vision at every visit and look for any esophoria or ET developing at near. Additive therapies, because these all work by different pathways. One works by scleral strengthening and improving choroidal perfusion. One works by increasing dopamine levels in the retina, and the other works by peripheral hyperopic defocus theory mechanism. So actually, these different things that we have can be used as an armamentarium to work for a customized treatment for myopia control. So take-home messages would be patience and persistence. And patience and persistence mainly from us we have to devote some more chair time to reinforce lifestyle changes. Prevention is better than cure. And to prevent myopia, outdoor activity is very important in daylight. Control measures imply progression. So document cycloplegia and axial length. Look for adverse effects. In atropine therapy, you have to look for rebound phenomena. So taper the drops slowly. Customized treatment. So it has to be customized based on what the child requires at that point in time and what the parents are comfortable with. Thank you very much.
Thank you so much, ma'am. Thank you. That was extremely well covered. So there's a question about amblyopia, about anisometropic amblyopia. So in those cases, what is their age cutoff for treating an amblyopia patient with occlusion therapy?
With occlusion therapy. So I mean, I'm okay with even a 21-year-old If they've never patched before in their life and they're willing to patch, I will give them a trial, because we do know now that there is some significant role of neuroplasticity, because a lot of the new vision therapy modules show improvement in vision even at older ages. So I'm sure amblyopia therapy, even in occlusion therapy, will work. However, the problem is going to be with what is the compliance that people will have. Older children or older adults will definitely not be okay with using patching therapy. So what is most important, I think, history of having patched before. If they've never patched before, then I will always recommend patching first, and the age of the patient. So if the age of the patient is older, I may tell them that, okay, you can go ahead with any of the other software-based therapies, which are proven. For example, revital vision therapy is proven to work for older adults.
And for how long? For how long would you do the patching? For example, a 21-year-old.
Yeah.
So
3
for
months
how?
is the first thing. So you patch for 3 months, see the patient on 3-month follow-up. If there's absolutely no improvement, stop patching. If there is any amount of improvement that you see, and it has to be documented in letters on an ADDRS chart, not on Snellen as 6 parts and 12 parts, because we do not know how many letter improvement we are getting. So if you have any letter improvement, then you go ahead with treatment. If it doesn't, just stop. Move to
And
the
what if the patient also has an exotropia in that eye, in which is not seeing because of the amblyopia? The fundus is absolutely fine, but because of the amblyopia, because of so many years of just focusing with the other eye, patient also has an exotropia. Then also, would you think that the patching therapy would work?
So sensory exotropia is what you're talking about?
Yes.
So depending on the age of the child, depending on the refractive error, sensory exotropia may not recover very well. So you ask for the history of since when is this person squinting. If it is a recent onset squint, of course you can advise patching. But if it is a long onset squint, you know that it is chronic and it's going to be very resistant to patching if the patient is older.
And I think if your vision allows you to patch, you can try patching. So even if you patch the other eye and exotropia becomes the active eye, of course, you can go ahead and try patching.
Yeah. And again, how many hours a day? What dictum would you follow? Is it like only dependent upon what is the power of the myopia, or how does it work?
For patching therapy?
Yeah.
Patching therapy is not determined. So the entire series of PEDIC studies that were done, the patching therapy is based on the vision in that eye. So we are looking at vision and not the refractive error at all. So whatever may be the refractive error, depending on the vision loss, you determine the amount of patching hours. So typically, if you have mild amblyopia, so 6-18 types, you give 2 hours of patching only. Because studies have proven that even if you do 6 hours of patching or you do 2 hours of patching, it works equally well. So you're not going to put that subject through 6 hours of patching. However, if you have moderate amblyopia, you'll go to 4 hours of patching. But if you have dense amblyopia, like 660, you will put the patient on 6 hours of patching. If there is a younger patient, you put them on, like if there is a very young infant who has an infantile ET or XT with amblyopia, I'm going to give them 50% of waking hours as a patching therapy.
I have a question. Dr. Pooja, if we're talking about patching for lesser amount of hours, for example, if you have to patch the patient for 2 hours, are there any particular activities that we want to tell the patient to have at that time? And
so what is said is that 1 hour of near activity, and that is recommended. So in 2 hours, 1 hour, or in 4 hours, 1 hour, or in 6 hours, 1 hour. Now, I typically tell the patients to patch when you're back from school, if that permits, so that you're off social stigma and the patients are more compliant. And of course, they have homework to do that time. So you tell the patients to use 1 hour to do homework and 1 hour to play or watch TV or whatever if you have to give. So if they have that 30 minutes of TV time that they're going to get, give it only if you're going to patch for that 1 hour, so that, you know, you made the most of the patching bribe.
And do video games like work better when they're doing that near work? Like if they can see, for example, they have a 636 or a 660 vision, and would you recommend them to play video games? Because that is what I've heard in a lot of lectures. Some people say that video games tend to, you know, work better than just, for example, doing a homework or something like that. No?
There's no evidence for that.
No evidence.
In fact, a lot of the vision therapy-based softwares, also Dioptica, believe that they sometimes are better only because compliance improves.
Okay.
So there's
Okay.
absolutely no proof for that.
Not because they're following a particular point or following a car or something like that. That's not going to make a
There
difference.
was a study, compliance, of course, works beautifully. But neuroplasticity and video games have a direct relationship. There was a study on Call of Duty. This was way before dioptic training and vision therapy came. And they found, I don't know if because of compliance or neuroplasticity because of video games, they found that the group which was on Call of Duty did much better. So there was a time we were suggesting play Call of Duty, worked very beautifully for teenagers, and it had great outcomes also. But yeah, it's still evolving. There's a lot of new things happening. That's what makes it so exciting.
Also, one more question, if I may, for the pediatric ophthalmologist. What is the maximum age group up till which you all would prescribe atropine? Like, if there is somebody, for example, when we are looking at progressive myopia in maybe 17 or 18-year-old age group, and if we are seeing progression, should we be giving them pharmacological treatment or should we abstain?
There's absolutely no harm, because if you're documenting an axial length progression, it's just going to work on the same retinal dopamine levels, and it's absolutely okay to use it. In fact, we're having more patients now that, of course, not in large numbers, but there have been a few patients that we've seen who are progressing in their 20s and 30s.
That's
because right. I mean, I don't know the exact reason why that person's progressing at that point in time, but you can start the patient on this thing because it's finally an RCT which has told us that this is the age limit that they used, but that doesn't change the retina at 18 years of age.
And the cutoff would be, I mean, the criteria to start would be progression in axial length or progression in refractive error?
Refractive error of 0.4, 0.5 diopters, and axial length of 0.1 millimeters per year.
Okay. Thank you so much.
Thank you so much, everyone. We are so glad to get such pearls of wisdom from our esteemed speakers. I'm sure that this webinar has helped all of us for our everyday practice. And for those who missed it, it's saved on our channel for future references and re-references. We will see you all next month, 7th and 8th of October at the physical IRSI physical meet, where we'll be having a physical Youthful session. And for those in Delhi and those who are planning on attending the IRSI conference in Delhi at Pullman, Aerocity on 7th and 8th of October 2023, we all will see you there. We would also like to thank our microvision team, Mr. Ashok and Mr. Navneet, for all their help at the back end, for always having this event run so smoothly. Thank you, and thank you for your active participation. See you all next month.
Thank you, everyone. Good night.
Thank you.
Nice.